Hello everyone, welcome back to your lecture session on overview and integration of cellular metabolism. We are continuing with nucleotide metabolism, and this class will focus on disorders of purine metabolism. In the last class we have discussed how purine is synthesized. So in this class we will be discussing how they are degraded, how it leads to a disease of uric acid production and hyperuricemia. We will be discussing about uric acid, we will be discussing about diagnosis and treatment of gout, we will be discussing other inborn errors of uric acid metabolism, diseases that are produced due to defective purine catabolism, as well as the salvage pathways. We will be covering it all. So regarding nucleotide degradation, right, we discussed how nucleotides were being synthesized in the last class, purine nucleotides. So regarding degradation, mainly what we need to know is nucleotides, actually ultimately nucleotides are monomers of big DNA and RNA, nucleic acids, right. So whenever we are eating any animal protein, any plant product, they have got all DNA and RNA inside them, right. So when they are degraded, ultimately they are nucleic acids, right. So nucleic acid actually can survive the acid of the stomach. However, they cannot, when they go into the pancreas, they are acted upon by pancreatic nucleases. Nuclease means the enzyme which cleaves these nucleic acids, right. And also intestinal phosphodiesterase, you know, DNA, RNA, those are basically nucleotides connected by 3' 5' phosphodiester bond. So the enzymes that breaks those bonds are known as phosphodiesterase. So when these nucleases and phosphodiesterase enzyme acts on them, they are hydrolyzed. Basically they are hydrolyzed and they are broken down into small nucleotides. However, since they cannot pass through the cell membranes, the phosphate group is actually broken off further and they are ultimately turned to nucleoside. Very important, in last class we already discussed about nucleic acid chemistry, what are nucleobase, nucleotide, nucleoside. It is a very fundamental thing you should remember, both during synthesis and degradation. Next, nucleosides may be directly absorbed by the intestine or may undergo further degradation to free bases, right. So two enzymes mainly act on that. Number one, nucleosidase enzyme, which can convert the nucleoside to free base and ribose sugar. Basically these are the two things that make up nucleoside. There is another enzyme, that is nucleoside phosphorylase. What it does, it requires an inorganic phosphate which acts with the nucleoside and it converts the whole thing to a base and one ribose 1-phosphate, all right. So these are the two basic mechanism, right, that it is true for all nucleoside. Now if we look into the biochemical pathway where these two enzymes fits, this will be it, all right. So you can see in the first step, all the they are being first broken down by nucleotidase, all right. So now what is happening, nucleotidase is breaking down all of them to their corresponding nucleosides, all right. Next, what is happening, nucleoside phosphorylase is again breaking down these nucleosides to ribose 1-phosphate as well as simple bases. Over here this pathway shows the application of nucleoside phosphorylase, but know this, there are also nucleosidase enzyme that can directly convert this nucleoside into base and ribose, that is not shown here. We are showing nucleotidase because when there is phosphate, these are nucleotides, all right. One very important thing over here, you can see all of this pathway, right, they are converging to this molecule, that is xanthine, which is actually acted upon by the enzyme xanthine oxidase to produce uric acid. You know, the xanthine oxidase enzyme has got some speciality. What you need to remember, it contains an FAD, molybdenum metalloenzyme and iron. It also requires iron as a cofactor, and this reaction is one of the rare reaction that produces reactive oxygen species, all right. So H2O2 is produced in this reaction. What else do we need to observe in this or remember from this chart? Xanthine oxidase acts not only once but also twice. You can see hypoxanthine to xanthine conversion also occurs by the same enzyme, that is xanthine oxidase. This reaction also produce hydrogen peroxide. And adenosine to inosine, this conversion is done by the enzyme adenosine deaminase, which is also abbreviated as ADA. Whenever we are later in the slide, when we are discussing various disorders, all these names will be very handy. So, adenosine deaminase, purine nucleoside phosphorylase, xanthine oxidase, all of them are very important, right. So, why at all we are bothered about these disorders of purines, alright, purine metabolism disorders, why they are so important? It is very important because these disorders may present with many variable symptoms, right. So, they can range from a simple rise of uric acid to kidney failure to a condition where uric acid rise leads to inflammation of joint known as gout. It may lead to neurological effect like seizure, muscle weakness. It can lead to developmental disorder, mental retardation. It also, all of these, some or the other purine metabolism disorders exhibit these features: compulsive self-injury and aggression, I mean self-harm, right, immune deficiency, deafness. So, there is a varied range of symptoms. The problem may lies in the purine metabolism defect, alright. So, we should know that both purine synthesis and purine degradation may have some problems, due to which there may be many diseases which we will be discussing very soon will have these features which are also overlapping among many symptoms. Now, what are the main mechanism, the basic mechanism? So, two types of disorder may happen, right, especially that is one that may arise from blockage in purine nucleotide degradation pathway when you are considering the catabolic disorders of purine, right. So, when purine is blocked from degradation. Next is increased activity of nucleotide degradation. So, either it is blocked from degradation or there is increased activity, I mean there is excess production of waste products of purine, alright. So, under these two headings it may be classified broadly. We will again be looking into the mechanism. So, the common symptoms that are produced when there is a block in degradation are immune deficiency, alright, myopathy, that is muscle disorder, and stones, renal calculi means stones in the kidney. Whenever the opposite is happening, that is excess or increased degradation of nucleotide, the symptom are characterized by hyperuricemia and gout. A common symptom, that is renal stones, and anemia or acute hypoxia, alright. So, one of them may come as a multiple choice question and an all except symptom may be given. So, you need to be very mindful. For example, immunodeficiency does not occur in diseases which are characterized by increased degradation of nucleotides, alright. It only occurs in a block of degradation pathway. So, be careful. So, we need to know about uric acid. We saw the final product in purine catabolism was uric acid, right. This is the end product of purine metabolism in humans, and whenever there is excess accumulation of uric acid in blood, it is known as hyperuricemia, alright. So, what is the problem? See, uric acid is 2,6,8 trioxypurine. Now, you already know how to number the purine nucleotide. You can easily number this and you will find out the oxo or the keto group is in the 2, 6 and 8 position, right. Uric acid is actually highly insoluble. Therefore, a slight alteration in the production or solubility will increase blood level. See, humans prefer urea as an excretory material. Uric acid, we are not uricotelic, we are ureotelic. Uricotelic are birds that especially those animals where they have adapted in such a way that there is less water intake, they prefer uric acid excretion. Uric acid is highly insoluble. So, even if there is slight increase, there will be problem in solubility, and that is why due to pure solubility, blood levels are usually at the maximum tolerable. Our internal homeostasis is in such a way so that the maximum uric acid that is produced is actually physiologically soluble. Any excess production or any problem that leads to an over level of uric acid above normal will lead to insolubility. And what will happen if there is insolubility, we will be discussing very soon. Now, you see uric acid is actually filtered through the proximal convoluted tubule, and it is also reabsorbed. I mean, it is filtered through the glomerulus, right? It is coming out, but majority is getting reabsorbed in the proximal convoluted tubule. However, urine has got uric acid. Uric acid is a normal constituent of urine. So, where is that uric acid coming from if more than 90% is absorbed? It is because it is also secreted. So, uric acid is also secreted in the tubule. So, mind it, in the renal tubule there is a process called reabsorption. In renal physiology you must have read, where the element or the compound of interest is being reabsorbed into the circulation. And what is secretion? When it is secreted via the tubular lining into the renal tubule, something which is not filtered. Okay. So, uric acid is filtered, reabsorbed as well as secreted, right? And this renal secretion, it may be enhanced by certain drugs, for example, probenecid, sulfapyrazone. These are drugs that actually block tubular urate reabsorption, and hence once it is secreted it cannot reabsorb, and thus uric acid is excreted in urine. This is one mechanism we should know, and this concept will come handy later on whenever we are discussing treatment of hyperuricemia. Anyway, 75% of living urate, that is leaving the body, is in urine. The remaining 25% of uric acid is broken down by the intestinal bacteria. That process is known as uricolysis. So, again uric acid filtered, majority reabsorbed. Again most uric acid is also secreted, a high amount is secreted, and of them, I mean that the secreted amount is actually almost 3/4 of the uric acid that is leaving the body via urine, and 1/4 is actually metabolized or broken down in the gut via intestinal bacteria. So, we have discussed hyperuricemia. So, what is hyper? What is the cutoff level beyond which we will claim it to be hyperuricemia? The level, you should all remember, it is more than 7 mg per dl in male and more than 6 mg per dl in women. So, it varies. The normal value in males and females are, the reference range or the reference cutoff value is different in male and female. Males generally have got higher level of uric acid. Why? Again the answer lies very soon. Now, how uric acid can be increased in blood, right? If you conceptually think, there are only two ways. Number one, it is produced in excess, right? And number two, the outflow is stopped. So, decreased excretion. So, overproduction or under excretion, these are the only two possibilities by which uric acid level can be increased in blood, right. So, what are the factors that contribute to uric acid, I mean hyperuricemia? Very easy, you can conceptually guess. Number one, increased synthesis of purine, which is also known as primary gout, all right. There is a process by which the normal metabolism of nucleotides are enhanced, all right. What is secondary gout? Secondary gout means there is overproduction of uric acid, not due to a change in the pathway, all right. It is rather more and more destruction of purines related to some other cause, all right. There is more available material to be converted to purine. That is the concept of secondary gout. Primary gout means overproduction of uric acid just like that, without any underlying reason, okay. Next, excess intake of purine, increased turnover of nucleic acids. These are all reasons which will ultimately be degraded to produce excess purine. So, generally what are the factors that are contributing to hyperuricemia? Number one, as I have discussed, sex. Plasma uric acid is higher in male than in females, all right. So, males are more predisposed naturally to hyperuricemia. Next, obesity. If the person is obese, obese people tend to have higher level of uric acid or urate in plasma. Remember, in plasma it is present as urate crystals, especially urate salt, sodium urate, right. Next, diet. It is a very important factor which contributes to hyperuricemia, subject to it higher protein diet. All right, for example, a person who is trying to build his body, all right, build muscle, or due to any reason his dietary habit includes Western diets, there are more protein component in the balanced diet. Those diet ultimately are broken down, and also and naturally, since it is high protein, also produce high nucleic acids, also rich in high nucleic acid, and all persons who also consume alcohol, chronic alcoholism especially, all of these, because alcohol, the edible alcohol, you can name any beer, whiskey, all any form of alcohol are also fortified with purines, and they increase the amount of purine consumption. Purine will be degraded to form uric acid. So all of these factors, sex, obesity, diet, they contribute to the hyperuricemia, right? Genetic factor, very important. Apart, even if all these factors are controlled, still it has been found the two different person will have different level of uric acid depending on something which is unexplained. So it generally it is thought to be a polygenic mechanism by which uric acid, or especially primary gout, is formed, right? I mean exhibited as a clinical disorder. Next, what are the conditions? Okay, you can say disease condition that leads to increased uric acid production. Malignancy. Why? Malignancy increase more and more cancer cell production, cancer cells degrade to form, the nucleus degrades, and then excess purine that leads to increased uric acid production. Ray's syndrome, Dyne syndrome, sickle cell anemia, all are increased with increased cell turnover. We will be discussing glycogen storage disease type 1 later. Next, again, hereditary fructose intolerance. What happens? You know, in hereditary fructose intolerance, the enzyme that is deficient is, that is your homework. You should be able to tell us by now what is the enzyme that is deficient in hereditary fructose intolerance. Remind it, it is time that you start revising all your lessons, because very soon we will be starting integration of metabolism, which mandates you to have a comprehensive idea about all metabolism, carbohydrate, protein, lipid, nucleotide, right, so that we can tie all together. It is easier for you to understand. So hereditary fructose intolerance should be something that you revise. Anyway, let me tell you, in hereditary fructose intolerance, the fructose is trapped as fructose 1-phosphate. Ultimately, what happens, since excess fructose is converted to fructose 1-phosphate, there is depletion of ATP, and more AMP needs to be produced to form ATP, and more AMP production ultimately leads to more AMP destruction. So increased production of nucleotides. Again, the whole thing, each and every one of them can be again due to medium chain acyl-CoA dehydrogenase deficiency, excess production and decreased excretion. All of these have got similar mechanism by which it can contribute to a higher uric acid production and leading to hyperuricemia. Well, often we use the term hyperuricemia and gout synonymously. Mind it, hyperuricemia is a clinical condition that is characterized by excess uric acid in serum that is more than level of normal. It can be a finding in routine examination. Suppose I have given my blood for routine screening. I am a very health conscious person. My blood glucose level is normal, urea, creatinine, those parameters, liver functions are normal. Suddenly I see my uric acid level is very high. What is the diagnosis? I have got hyperuricemia. But do I have got gout? No, because gout is completely, it is used synonymously in most cases, because hyperuricemia leads to gout, but gout is actually the disease where there is accumulation of monosodium urate crystal that are deposited, resulting inflammation in joints and synovial membranes and basically joints, all right. So synovial joints are characterized by deposition of needle like monosodium urate crystal, leading to acute inflammation, excessive pain, leads to production of this disease that is known as gout. What are the characteristics? Hyperuricemia, acute inflammatory arthritis means pain in joints, also uric acid nephrolithiasis means formation of uric acid stones in the kidney, all right. So often it is a monoarticular disease. There are multiple reasons of joint pain. There are multiple systemic disorders, for example, rheumatoid arthritis, osteoarthritis, psoriatic arthritis. There are multiple reasons. You can find the reasons of arthritis in any standard textbook, or you can even search online and you will get the answers, but most of them are characterized by multiple joint involvement. Whereas initially, to start with, gout almost always presents with involvement of a single joint, and due to the gravity, that is normal physiology, uric acid crystals tend to get deposited in the lower part of the body. And what is the most important joint in the lower limb? That is great toe. Alright. So, metatarsophalangeal joint of great toe is most commonly the first affected joint, is generally the first affected joint, and pain, isolated pain in right or left great toe with all the symptoms, suppose age, high purine diet, chronic alcoholism, should have a strong suspicion for gout. Alright. So, uric acid level should be checked. However, monosodium urate crystal, which are also known as tophi, can be deposited in elbow, knee, feet, helix of the ear, as you can see in the photos, in interphalangeal joints. Now, this disease was discovered very early. It is not a recent disease, because we have got purines in our system. Alcohol has been consumed since ages, and purine degradation is also since ages. But even before it was discovered, the pain in great toe was there, and there have been references even ancient in scriptures that a disease where invisible demon is biting the great toe. Alright, this is a illustration by James Gilroy in early 18th century, 1799. Alright. So, mind it, the pain in great toe is almost synonymous with gout. This is a nice history of gout that you should keep in mind. Anyway, as I discussed, primary gout and secondary gout. Primary gout means again caused by either overproduction or decreased renal excretion, or both. Mainly occurs in middle-aged men. Men are more predisposed, but the biochemical etiology is not known. It is considered a polygenic disease. We cannot clearly pinpoint what problem I am having. Suppose I have been diagnosed with hyperuricemia just like that. Many individuals get diagnosed with more uric acid just like that. Males, females, irrespective, but males are more predisposed, but we cannot pinpoint a single reason if all other findings are alright. Okay. Whereas in secondary gout, it can happen in both children and adult, and it is characterized, I mean, there are underlying reasons that lead to in rapid tissue breakdown or cell turnover, and that can also lead to, I mean, mechanism of gout by two reasons: increased production or decreased clearance. Alright. But know this, in primary gout there is no such obvious reason, whereas in secondary gout we can pinpoint this is the reason that has led to increased cell turnover, increased nucleic acid turnover, or some drugs that has led to gout. Alright, that is secondary. So, whenever you can pinpoint some reason due to which it is happening, it is secondary to that disorder. And in case of primary gout, just hyperuricemia and gout is there, but no single etiology can be pinpointed. So, what are the hereditary disorders that are associated with gout? Means these are the disorders that are lying in the nucleotide metabolism pathway. Alright, or there is some enzyme defect that is present since childhood. So, hereditary, inherited. Those are number 1, HGPRT deficiency, hypoxanthine guanosine phosphoribosyl transferase, we have discussed in purine salvage pathway. Superactivity, that is more activity of PRPP synthase. This is an enzyme that was regarded as the step 0 of both purine synthesis, purine salvage pathway, de novo synthesis, salvage pathway, as well as it will be required in pyrimidine synthesis. So, step 0, that enzyme PRPP synthase superactivity, or rather it is synthetase. Alright. Next, glucose 6-phosphatase deficiency, you already know, von Jark's disease or glycogen storage disease type 1. The problem in all of these, what is the exact etiology, we will be discussing later. Okay. So, we will be touching all of them one by one, but this is a rare variety of, since we are discussing gout, these are all the reasons that can lead to gout. Okay. So, there is one rare variety, that is familial juvenile gout, also termed as familial juvenile hyperuricemic nephropathy. So, it is a autosomal dominant type of disorder in which there is severe renal hypoexcretion of uric acid. So, the clearance is actually defective, all right, due to problem in transporters of uric acid. At first what happens, the hypo excretion of uric acid is reported in the childhood, and by the time the patient goes to adulthood, renal failure can happen. So, ultimately the symptom of renal failure are presented in adulthood, generally at the 3rd decade of life. However, in some cases it has also been reported that the disease has expressed itself in infancy. The main problem lies in hyperuricemia and gout. Since uric acid cannot be excreted properly, it leads to accumulation in the serum, leading to hyperuricemia and gout. Next, it is a familial renal disease, as the name suggests, since it is autosomal dominant, the disease runs in family, and generally there is low urate clearance with respect to the glomerular filtration rate. So, normal clearance with respect to normal individual, the urate clearance is actually very low. So, the common treatment for gout is actually inhibiting formation of uric acid. So, how can we inhibit formation of uric acid? By attacking the enzyme that is responsible for uric acid formation, and the compound that are available with us to target that specific enzyme of uric acid degradation is allopurinol. Okay, it is a competitive inhibitor of the enzyme xanthine oxidase. We have seen xanthine oxidase actually acts in a 2-phase. So, once xanthine oxidase is inhibited, how in competitive inhibition the inhibitor is a substrate analog. So, it actually, xanthine oxidase acts on hypoxanthine to produce xanthine. So, since allopurinol looks like hypoxanthine, it can actually fool the enzyme so that it can uptake allopurinol, and then uric acid will not be formed, right. Generally alloxanthine is formed. So, see, other than treatment with these xanthine oxidase inhibitor, all right. So, there we also need treatment with, so you can see there is also another inhibitor, allopurinol and febuxostat, FEBUXOSTAT. So, febuxostat. So, why we have got 2 drugs? Febuxostat has been discovered much later, because one has got high renal clearance and one has got high hepatic clearance. There are scenarios in which there is hyperuricemia with renal failure. So, the excretion of allopurinol will be hampered, and there are also situations in which there is hyperuricemia with liver failure, then we need to stick to febuxostat. So, depending on the patient condition, we need to adjust the drug. So, both of them are actually xanthine oxidase inhibitor. However, apart from lowering the uric acid level, we also need to control the pain and inflammation with the help of non-steroidal anti-inflammatory drugs. We can also use uricosuric drugs like proben acid, etc., to increase the uric acid excretion, right. Next, those patients that do not respond to traditional therapy now recently has been targeted with these drugs, that is pegylated uricase. Uricase, what it does, it actually converts uric acid to allantoin, which is easily excreted via the kidney. Not only that, the tophi can also be surgically removed. So, here you can see a uric acid crystal is being present in the 5th proximal metacarpophalangeal joint, and it has been removed. Okay. So, as I discussed, what are the inborn errors of uric acid metabolism? Number 1, purine phosphoribosyl pyrophosphatase. So, PRPP synthetase. Okay. This enzyme, if it is more active, what will happen? There will be excess PRPP, and as I told you, PRPP positively affects uric acid production, all right, uric acid production, and if uric acid production is more, it will be degraded more and more. So, this enzyme superactivity can vary, okay. It can be a very severe form which appears in infancy, and there is a mild form which presents in adolescence. In both the form, kidney or bladder stone is the first symptom, because there is excess production of uric acid. Apart from that, gout, impairment of kidney function may develop if they are not properly controlled, all right. The next enzyme deficiency that we need to know is adenylosuccinate lyase deficiency. Adenylosuccinate lyase, as I told you, when we were discussing about purine synthesis, de novo purine synthesis, this was a step 11. I told you by comparing it with urea cycle that aspartate is coming in, fumarate is going out. So, this is the step where this enzyme, if it is deficient, the previous products will be accumulated, AMP production will be hampered. What we need to know is this is a disease which is characterized by neurological symptoms, which includes abnormality, abnormal cognition, epilepsy, muscle wasting and feeding problems. So, mainly neurological symptoms are there in adenylosuccinate lyase deficiency. Alright. So, generally MCQ will hover around this. The neurological symptom, you cannot rule out adenylosuccinate lyase deficiency. Alright. So, what are the inborn errors of purine catabolism? Now, we are strictly focusing on catabolism. The first disorder is adenosine deaminase deficiency or ADA. So, when adenosine deaminase is deficient, what will happen? Adenosine cannot be degraded, right. So, basically adenosine and deoxyadenosine, both ribo and deoxyribo sugars are handled by the same enzyme. So, what will happen? Their concentration will rise, right. ATP and DATP will rise. What they do? They actually inhibit the enzyme ribonucleotide reductase. DATP inhibits ribonucleotide reductase, which is actually an essential element of DNA synthesis. Therefore, RBCs cannot proliferate, that is cannot grow. WBCs, white blood cells. So, major part of white blood cells are lymphocyte, T cell, B cell. So, their functions are defective, and these white blood cells are actually cells that are imparting immunity to us. So, adenosine deaminase deficiency is actually named as severe combined immunodeficiency. So, the immune system is highly compromised. Whenever the immune system is highly compromised, can you name any other disorder in which immune system is highly compromised? HIV AIDS is one such disorder in which steroid therapy, prolonged steroid therapy, immune system is highly compromised. What happens? Those organisms which are normally residing in skin, normally residing in air, which cannot attack us, now can cause infection. Those are known as opportunistic organisms. So, opportunistic infection are very common. Again, symptoms may include pneumonia, chest infection, chronic diarrhea, growth retardation. Apart from that, neurological problems, developmental delay can happen in ADA deficiency, and if it is not treated, if it is not diagnosed and treated, a child can maximum survive up to 1 or 2 years, otherwise he will die of infection, right. Next, purine nucleoside phosphorylase. So, this is the enzyme PNP, right. What it does, if this enzyme is defective, so there will be ineffective conversion of IMP to hypoxanthine, xanthine and guanine, right. So, basically inability to metabolize guanosine and deoxyguanosine, and ultimately it will lead to accumulation of their nucleotide. They also inhibit ribonucleotide reductase. The mechanism is same like ADA deficiency, but it is much less severe. So much so that only T lymphocyte function is affected, alright, whereas in case of ADA deficiency, both T and B lymphocyte are affected and there was severe immunodeficiency. Here it is mild immunodeficiency, alright, but both of them nevertheless fall into immunodeficiency disorder characteristic. There is a minor enzyme that we should know, that is known as myoadenylate deaminase deficiency, also known as muscle adenosine monophosphate deaminase deficiency, especially for MCQ. This may not come as a question in descriptive exams, but for MCQ it is very important. The disorder, the effect lies in the AMPD1 gene, which is the what happens basically that interferes with processing of ATP. Okay, you can see in the system what it is doing. AMP is getting converted to inosine via AMP deaminase, alright, and ammonia is being produced. So, if there is lack of that enzyme that converts ATP to inosine and ammonia, alright. So, you can see ammonia is actually produced with the help of this enzyme. Generally what will happen? There is no such severe symptom. Generally it is characterized by exercise induced muscle cramping, right, and the disorder is actually diagnosed through accumulation of ammonia or inosine monophosphate in the muscle. Okay. This typically treatment typically consists of exercise modulation. Mind it, most of these enzymes are actually reversible. So, the same enzyme also converts inosine and ammonia to this. Okay. So, if this enzyme is deficient, ammonia will be accumulated, IMP will be accumulated, AMP cannot be synthesized. Okay. So, you might be confused with the arrow, but these are reversible enzymes. Most of these enzymes are reversible. Next, xanthine oxidase deficiency. We know xanthine oxidase, the enzyme which was appearing the last in purine catabolism, is a rare hereditary disorder in which there is a deficiency of liver xanthine oxidase. So, catabolism of purine stops at the xanthine hypoxanthine level, which results in again formation of excess amount of xanthine and hypoxanthine, and hypoxanthine and xanthine stones are found. However, blood uric acid is very low, right, and there is high level of urinary excretion of xanthine. That is why it is known as xanthinuria. So, reduced excretion of uric acid. Additionally, this condition can also lead to muscle disorders, myopathy, because there is xanthine deposition in the muscle. Those xanthine stones, xanthine crystal may be deposited in the muscle. So, treatment involves avoiding food and drink that contain xanthine derivatives such as coffee, tea, Coca-Cola, and maintain a high fluid intake, so that the amount of excess xanthine can be dissolved in urine, right. And finally, we come to disorders of purine salvage pathway. Over there, we mainly need to know about two enzymes, number one, hypoxanthine guanosine phosphoribosyl transferase. That enzyme may be fully deficient, in which it is known as Lesch-Nyhan syndrome, or it may be partially deficient with similar symptoms but reduced intensity. We will be discussing those symptoms. And the second enzyme was APRT, or adenine phosphoribosyl transferase. All right. This results in accumulation of insoluble purine 2,8 dihydroxyadenine, and it results in only kidney stones and acute renal failure. APRT deficiency results in acute renal failure. But what does HGPRT deficiency or Lesch-Nyhan syndrome is? It is a metabolic disorder which we already know, characterized by the deficiency of hypoxanthine guanosine phosphoribosyl transferase enzyme, HPRT or HGPRT as you may term it. It is inherited in an X-linked recessive fashion, again characterized by hyperuricemia and hyperuricemia. Okay. Why? Because the purine nucleotides cannot be resynthesized, nucleobases cannot be resynthesized to nucleotides. So, they have to be excreted by uric acid pathway, leading to excess production of uric acid and the intermediates which lead to mental retardation. The disease is characterized very early, it presents very early as in the first year of life, and the symptoms are mainly neurological since it is affecting the brain. It includes facial grimacing, involuntary writhing, the baby coils on to himself, aggressive behavior, self mutilation, the baby bites his or her fingers, and repetitive movements. And the bad thing is there is no known cure. However, some cases with mild deficiency may proceed to adulthood. Here we can see a few cases where this is a mentally retarded child, the look it says so, as well as the condition where a child who has bitten his or her own fingers. So, self mutilation, aggressive behavior, multiple choice question, Lesch-Nyhan syndrome, HGPRT deficiency. Now, one very important thing that was left out is von Jark's disease. Why von Jark's disease leads to hyperuricemia? We already know von Jark's disease is a disease characterized by glucose 6 phosphatase deficiency. Therefore, glucose 6 phosphate cannot be converted to glucose. So, the majority, since glucose 6 phosphate cannot be converted to glucose, it will be diverted towards HMP shunt. HMP shunt, we all know one of the important product is production of ribose, which ultimately leads to increased production of PRPP and purine, and then uric acid. So, in case of glucose 6 phosphatase deficiency or von Jark's disease or glycogen storage disease 1, it leads to hyperuricemia. All right. In addition, glucose 6 phosphate can be converted by anaerobic glycolysis to lactic acid. We already know, because G6P is also diverted towards glycolysis. This lactic acid competes with uric acid for excretion. So, both overproduction and excretory defect, that leads to hyperuricemia in case of von Jark's disease. And lastly, this is a very we cannot call it a condition, or a disease, it is a condition known as hypouricemia, where there is less than 2 mg per dl of uric acid in blood. What is the problem? Again for MCQ, URAT1 gene is defective, that leads to secretory and reabsorption defect. All right. Again, uricosuric drug, a patient on uricosuric drug may actually develop hyperuricemia mainly without any gene mutation defect, all right, without any gene mutation. Again, hyperuricemia is also common in vegetarian, because vegetarian diet have got low purine content, but it is a good thing that this has got no recognizable symptom, and hence they do not require any treatment. So, to conclude, we have discussed about the degradation pathway of nucleic acid, we have discussed about uric acid hyperuricemia, we have discussed inborn error of uric acid metabolism, we have discussed disorders due to purine catabolism, disorders due to purine salvage pathway, diagnosis and treatment of gout, as well as hyperuricemia. So, these are my references, and I thank you for your kind attention.